Thank you all again for joining us today. On behalf of NIOSH-supported education and research centers throughout the country, we are pleased to present the 2019 Ergonomics webinar series, offering free monthly webinars on various topics on human factors and ergonomics. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Thank you for joining us today. Today's webinar, A Patient Handling Story from Patient Migration to Repositioning, is brought to you by the University of Cincinnati and Dr. Kermit Davis. A few housekeeping items first. You will be muted during this presentation. If you would like to ask a question, please enter it into the online chat or Q&A. We will save time at the end of the presentation to address questions. This webinar will be recorded and archived for viewing on COEH Northern California's YouTube channel. At this time, I'm pleased to welcome our presenter, Dr. Kermit Davis. Dr. Davis is president of the Human Factors and Ergonomics Society, where he became a fellow in 2013. He's also the graduate program director of the Environmental and Occupational Hygiene and Occupational Safety and Ergonomics programs at the University of Cincinnati. His current research is focusing on the investigation of the effect of physical workplace demands, as well as mental workload, on the responses within the lower back. In recent years, Dr. Davis has concentrated on reducing ergonomic stressors of healthcare workers and patients in healthcare settings. Thank you again for joining us. We look forward to your presentation.
Well, thank you for having me. Yes, I'm going to be talking about patient handling, and particularly how patient migration in hospital beds or any patient beds leads to oftentimes repositioning, and this is really where the detriment towards the nurse and nurse's aides. I'm going to start with a little bit about putting the story in perspective, and that is that the back injuries are quite prevalent in nurses. If you look at the lifetime prevalence is around 60%, 70%, and if you look at an annual percentage of 52% of a major injury, then all the way down to an actual injury where it's taking lost time, around 20% of the nurses and healthcare workers that are in healthcare facilities result in back injuries. If you put that into context, that has always been the major concern for nurses and nurses' aides. You always hear about their back injuries and that, but certainly that is not the only issue, and that's only a tip of the iceberg of the pain that these individuals are experiencing on the job. If you look at other body regions, you have a hit or miss on understanding the types of injuries that you have. So that these are all this data I'm showing right now is through a review article. So each of these dots actually show a study and inventory of all the studies that are out there looking at healthcare workers, particularly nurses and nurses' aides. But if you look at shoulders, we don't have a much of an idea of what's really going on with the lifetime prevalences. But we certainly still have a significant amount of pain in the annually, as well as current pain, as well as lost time injuries. Again, you get a little less data for neck injuries, and so, but we still have a good percentage of around 50%, 45% of individuals have some type of pain throughout the year at one time, and then you still have a significant number of lost injuries due to neck injuries. Similarly, you have issues with upper extremity injuries, and you have a small prevalence of that, again with annual, but a lot of missing data in upper extremities, and finally similarly with the lower extremity. So what you get a picture of is there's a lot of pain and discomfort that's occurring annually as well as currently for nurses and nurses' aides. And that often transfers into significant injuries, musculoskeletal disorders, or lost time injuries down the road. And it's not, while low back pain is certainly a significant injury for nurses, it's not the only injury that occurs, but it is oftentimes what is the primary focus. Now, what leads to these injuries is certainly a talking point. Patient handling obviously is a huge issue. It accounts for about 56% of the injuries that are occurred to nurses, and that is both with transfer in and out of bed and overall patient handling. But predominantly, if you look at the literature on what you end up having is a propensity for repositioning to be equally or even oftentimes exceeding the injuries. A recent study that I did with Kent Wilson, analyzing several hospitals across the nation, resulted in repositioning being the number one way a nurse gets injured in the hospitals. So it is a task that is routinely done, oftentimes at a minimum of every 2 hours, that the patients are usually moved in bed and repositioned up in bed, and then oftentimes even more than that. If you look at a recent study that we did, looking at ICU units, where we went in and we looked at what activities nurses do throughout the 12-hour shift. And what you find is, actually handling and transferring in and out of bed, or from bed to chair, bed to wheelchair, it doesn't really happen that often. And it's not too surprising. This is ICU units, intensive care units. So you don't have a lot of that, but by far the number one activity is body repositioning. And this was moving patients up in bed, often occurs routinely throughout a 12-hour period of time. So they were doing this very often. Obviously, this isn't just one patient getting moved 30 times. This was each of the nurses throughout the day looking at multiple patients, oftentimes about 4 per nurse. So, it is a highly utilized task that is being performed, and as the epidemiology has shown, it's one of the most damaging to nurses. So why do nurses reposition patients? That's the real question here. Oftentimes, if you are in a hospital or a long-term care facility, nurses worry about a few things. One is they worry about a patient sliding down the bed and having their feet touch the footboard, and that ends up causing potential pressure ulcers, as well as other issues. And so when they see a patient down in bed, they pull them back up and repositioning them. And we'll go through some of the ways that a person goes and is migrated down the bed, but that certainly is a concern. But if you look at how a patient moves down in the bed, there's 2 ways of doing that. One is active patient migration, as well as passive. And the first one is active patient migration. And this gives you an example of it. As a person's head is articulated up, so you want to be able to see the TV or talk to the people that are around you, or you want to adjust them to have a different position in their upper torso for their lungs. There's many reasons why you would actually have them being sitting upright. But as you can see, just raising a bed up and raising the head of the bed, you can see visually how the feet slide towards the foot of the bed just by articulating. So as the articulation is moved up and you're sitting up, the body slides down the bed. Now, also you can have passive ones where you're upright, you're sitting up there, and just by having the position upright on the bed, gravity will push you down in the bed. And so as you saw in here, whoops, you were able to, you over time will slide slowly down, not as much as the active patient migration, but you will slowly move down due to gravity being pushed down on your upper body and pushing you towards the foot of the bed. Now, what is the negative outcomes of patient migration? If you're laying flat on the bed, you'll typically have pressure points at the back of the head, the shoulder, the lower back, the lower torso, as well as the heel. And each of those pressure points, over time can cause detrimental effects to the tissues and breakdown, and that ultimately will cause you to have actual tissues to break down and ulcers to form. When you're in an upright position, those forces act a little more complex and in different directions as you're being pushed forward. So it creates a friction force as well as pressure forces within the various components. So, and then if you add in various types of moisture and heat, you get tissue breakdown and you get some nasty sores, pressure sores and pressure ulcers and bed sores that become effective and can be very, very painful. And so this is one of the things that the hospitals care about, because they're not covered necessarily by insurance, because it's something that they develop while they're in the hospital, and so they have to worry about these type of things occurring, these type of sores occurring, because it's expensive as well as it's very painful for patients, and you don't often have good health outcomes if you're in pain additional to in these sores. And so this is a really big concern, and this is why oftentimes the caregivers are tasked with repositioning of the patients throughout the day, as well as making sure that their bedding is appropriately cleaned, which also causes them to move patients quite readily. Now, there are also other negative effects, and one is to worry about the effect on the caregiver. So any time that you have a patient moving that's needs repositioned, the widely used task or technique is the two-person draw sheet, where you get a partner to come in and help you, and you drag that person up in bed. And actually, it's kind of interesting that this video is kind of showing not necessarily the best methods, because oftentimes what they'll do is reverse trend the bed and use gravity to move the patient down. The problem with this repositioning is obviously it's putting a lot of stress on the caregivers, but also you're putting stress back onto the patient when they're being moved back up into the bed. Oops. And so those repositioning, as we'd shown earlier, leads to injuries. And as I said, we just did a recent study where we looked at 53 hospitals, and we found that repositioning was by far the #1 leading factor for injuries in hospitals, and particularly it was #1 across the board, and I think about 89% of the hospitals, it was the number one factor. And then in the other ones, it was number two factor. So it was the leading reason of back injuries for nurses. So this led to a study of, can we design a bed so that you don't move down into the patient doesn't move, so you don't need to reposition. And as you see, there's 3 different types of beds that we evaluated. The top right one is a complex. As you can see, the patient that's laying in the bed is moving or not moving very much as the bed kind of elevates its head, and it also provides the upper part or the lower part of the headrest moves back as it is elevated and articulated. The single pivot, as you can see, will tend to be a single pivot that will push the patient directly down in the bed, and will move the feet towards the footrests pretty dramatically. And then a double pivot bed was basically, instead of a single pivot, it was a little more complex pivot, but it doesn't have the release of the articulating upper head section to allow the pressure to kind of be relieved on the patient. And so we evaluated these through both an active phase of where we articulated the headrest, the head section up up to a 45-degree angle, as well as doing a study where we looked at passively, where they were set up in upright position to understand how gravity impacts the migration and how much is contributed by gravity in an upright position versus the active articulations. When we did this, we started patients in a flat position, and then we moved them up to 45, and then lowered them to a flat position. And what we did is, and these certainly are not, the dots that are showing are not the actual markers, because they're much smaller and you couldn't really see them. So we used basically a white dot that overlaid the individual markers. You can see one on the actual bed mattress on each of the pictures here, where you can see how small they are. But what these markers show are the bony landmarks that we use to identify the various segments of the body, starting with the temple, the shoulder, the elbow, the greater trochanter, the hip, and the knee and ankle. And then we also markered up each of the sections of the bed frame so we can understand how the bed is actually moving relative to the body. And so that's what the lower markers on the bed are showing. And what we tried to do is look at how much a person moves in bed relative to the actual, to the frame of the bed and the mattress also. And in the first case, when we're trying to define how much migration is going on, when as you migrate or articulate the upper head section to a 45-degree, we can understand by looking at the markers relative to the sections of the bed. And in a simple format, this is what you're seeing here is the markers for the person, and then looking at it relative to the bed. And then you're looking at a given section. So this would be the hip marker or the greater trochanter relative to the thigh section of the bed. And you're looking at that distance relative to when it is in an upright position. And those also can articulate. So you're looking at how much distance you're moving down relative to those sections as they're moving. And you can get an understanding of how much distance is traveled by looking at that distance. And then that would be the net migration down when you're in an upright position. One other factor that we looked at is torso compression. And so one of the things is you can certainly put something that stops the feet at the bottom, and so you don't migrate, but that's going to result in what we call torso compression, where it documents the distance between the shoulder and the greater trochanter. And, excuse me, that distance provides an estimate of how much you get, really how you get balled up, or how that your torso gets shrunk to as you're articulated up. And so one of the things that it does is tells you basically how much you're getting balled up, or how much you're maybe at some level discomfort as the bed is pushed down, particularly when you end up giving some type of resistance against the lower extremities that happens. So it's a trade-off. You can certainly eliminate the migration that is moved down in the bed, but that could also result in torso compression that you want to make sure you minimize. So when you look at the actual documentation, you get a very interesting picture, particularly when you look at different types of articulation. So this is a repeated articulation 3 times, and as you can see, the ankle is moving totally different relative to the foot section, as the trochanter moves towards the thigh section, and the shoulder moving to the upper the head section. So there's they're not the simple transition of one part of the body is moving the same relative to the bed as other parts of the body. And obviously one of the biggest points of seeing when things happen is in that first articulation. Takes a lot of, you're getting almost 2.5 to almost 3 inches of movement in the bed each time. And so this is showing you just how much variability you have in 3 articulations over the time. And as you see, you're moving farther and farther down the bed by the end. So even though that you're at the start, up over here, you start at a 0 distance. By the time you go through 3 articulations and you're laid back out flat, you've moved down the bed a whole inch in a position. But as you go through each of the articulations, you're going to be down significantly in the upright position, close to 2.5 inches down in the bed. So if you look at the net migration for the 3 beds, design really makes an impact. This complex pivot point really reduces, and you only have, and this is in centimeters. I apologize for switching back and forth. I didn't catch that on the previous slide. But this is in centimeters. So about 1.6 centimeters of total migration that occurs in that first articulation, compared to almost 10 centimeters in bed B or C. And so there's quite a bit of reduction by using this complex type of joint pivot in the head section. If you look at the cumulative loading or movement, that's when you have the movement up and down, and you're measuring the distances, both the movement down in bed and then back in bed, and looking at the different articulations. So what this is showing is you really move, even in the complex, the bed A, you're moving down significantly centimeters down, but then you're moving back up into the bed. So after 1 articulation, you've moved 7 centimeters of total distance. But that doesn't compare to anything close to what you see in the beds A and C, where you're getting almost 20 centimeters down in the bed and then back up in the bed as it's laying down. That's partly due to the articulation and the friction between the bed and the mattress and the patient, and that will result in significant movement back and forth, which is causing friction forces as well as pressure forces that's occurring in bed. But as you see, it's a significant reduction with the more complex pivot of the head section. The torso compression is also, as I said, you can provide stops, and one of the things that you see is with these more simple types of pivots in the head, or in the articulations, you end up with a significantly more compression, torso compression. So you're scrunched more in those more simple, in the simpler type of pivots, where it's just pivoting around one point or a dual point of access. And you significantly reduce that again by a more complex pivot joint. So what you get is a trade-off potentially that you need to consider. And so one of the things that you can think of is when you're doing evaluations of whether you got a good bed or not in a hospital or a long-term care facility, there's some quick, easy things. You don't have to have the complex systems that we did to evaluate and measure the distances and movements in bed with the tracking systems that we use. You can actually just use a simple eye test or a ruler tape measure on the bed, where you can mark where your knees are or where your ankles are, and see when you put them up how far they move down in bed relative to each other. Or you can measure the distance between your hip and your shoulder as you're seeing the before and after. So certainly you can, as I said, you could put a stop like a foot pillow, or you could raise the knees, but that could increase the compression the torso compression. You can also look at how the various bed designs can the between this torso compression.
Hello, Kermit. We lost you there for a minute. Do you mind repeating that last minute or so?
Okay, sorry.
Thank you.
I'm not sure why. So I was saying that there's a trade-off between torso compression and as well as the movement of the body down in the migration down in the bed that you have to compare. Some of the things that you can do certainly is put a foot pillow or a raise of a knee that could increase the compression of the torso compression, so decreasing that distance between the shoulder and the hips. That kind of balls up the patient, but you have to worry about, and then that will reduce the normal transition of the body migrating down through normal articulations, but you do have to worry about the other torso compression. I was also saying that you could do simple things to measure how different beds in your hospitals and long-term care by just using a simple measuring tape, as well as going through a couple articulations to see how the ankles move towards the feet, move towards the foot of the bed, and maybe also measure how the shoulder and the hips get closer during the different positions of articulation. So there are simple ways to really document this, not in a sophisticated way we did. So one of the things I did say is there's both active and passive, and similarly we did a study. As you see, the first part of this is the active component, so that's one articulation up, and as you see the beds B and C and D articulated again up to 14 centimeters down in the bed. But they don't stay there. They continue to move throughout the 2-hour period after that, where we just had them sit in bed. And as you see, they move towards the foot of the bed. And with the beds A and B, A is similar as the one in the complex that we saw that I presented earlier. And this is just a small, B is just a small variation on that. But you see that there's a significant amount of reduction, again, only about 2 to 3 centimeters down in the bed through active. And then you actually get a longer, a more flat response in the trochanter, as well as the ankle is very similar results as this. So you really have some long distance worries or long time worries that you have to not only worry about the active, you still have to worry about passively when they're sitting upright as a contributor to migration. So as you see, migration is a huge issue, and I talked about when patients migrate down in the bed, you see that what happens is the nurses want to move them back up in bed because they don't want the pressure ulcers resulting on the feet and ankles, and so. But as I said, the number one way of repositioning a patient is to grab another friend and come in and lift the patient up bed, which is not necessarily very efficient or effective in reducing the actual stresses being placed on the patient or on the caregiver. And we'll talk about how you can reduce that with various safe patient handling devices. And one of the big things that you have to do when you have to find a friend, you have to go and actually negotiate with that person to come over and help you, and then oftentimes you got to go help them. So it's not a very effective way of treating patients and being attentive to them versus running around and helping people. In addition to the actual physical demands that we're going to be looking at in the next set of studies. So we did a study looking at repositioning studies where we looked at the third-person draw sheet, which is this upper left-hand corner. There's a maxi slide, two frictionless sheets on top of each other that are supposed to be designed to move the patient with less resistance. And then there was two air mattresses that create a air buffer underneath the cushion and the mattress of the bed that allows it the caregivers to move the patient up again. And similarly with this is a reusable version, and this is a version that's disposable. And then we did a fourth condition that we're not showing because basically it's the same as the two-person one, except you do a hard board that a rescue board underneath that they use to also reduce the frictions on the between the patient and the bed under that slide board. And what we found was the air resisted devices significantly reduced the compression and lateral shear forces during repositioning. It was and the dual friction reducing sheets as well as the slide board were very similar, a slight reduction but not significant for the draw sheets. And so both the complex loading, which you would expect with lateral shears and compression on moving a patient sideways, so you're getting a lateral forces being placed on the actual caregiver, are producing pretty significant amounts of loads on them. And manually was by far the most detrimental using the draw sheets, and that's why I would highly recommend not to be using draw sheets when you're repositioning patients. Hence why you're still seeing repositioning being one of the top ways a nurse aide gets hurt in the hospitals. So the other thing I'd like to talk about real quick is sort of come back a little bit to the new hospital where I see that the future is going, and that is home health care. Most of the devices that you see implemented, and even with lifting hoists and stuff, is in a hospital. I think that the home health care is a significant place where we're seeing the demands on caregivers are drastically different than what you see in a hospital. And we're doing some studies now currently looking at home health care, and particularly showing some of the unique exposures that you have. One of the things is, if you don't know already, is the home health care is the fastest growing sector of healthcare that's out there. It's projected to increase employment all the way up to 1.9 million by 2022. It represents a 43% job growth in nurses and a 48% job growth in home aides. And this is certainly a workforce that is growing quickly over the years, and often do not have the same resources as hospitals and long-term care facilities. This is an alarming picture. This is a study we're doing right now with Ohio Bureau's Workers' Comp database. And you see here is home health care workers have significantly greater injury costs than either long-term nurses aides and nurses, or hospital nurses or nurses aides. Almost double the costs that you affiliated with the injuries. So this is a cohort that's increasing rapidly and has some of the highest injury rates in healthcare that's occurring out there. So one of the things is it's a very unique environment. If you look at a hospital nurse or a long-term care nurse, traditionally they'll have 4, maybe 6, maybe 8 patients at the most in a given day or given work shift, and they're all pretty much in the same type of rooms. Sometimes it might be 2 in a room, but everything is a very relatively standard type of setup. The equipment is oftentimes around and easily usable, where the home health care is a very unique setup. You have to go where the patients are located. Oftentimes, every house is a new place, a new workplace every day. So you get multiple ones, anywhere from 4 to 6, oftentimes 4 to 6 homes per day. And then you have not only the interactions with the patient are different because you don't have lifting equipment. You oftentimes are in more cluttered areas with furniture. You have to deal with steps with egress and ingress. You have to deal with animals oftentimes running around. And this changes throughout the day. You don't get the same setup like you do in a long-term care facility or in a hospital. So when you're dealing with patients that reposition in their beds and moving them up, you don't have somebody to go get a friend to help you, a coworker to help you. You end up having to, at best case, is to help the informal caregiver to help you, but often they're left to move patients by themselves and do the same type of movements and that are involved in hospitals and long-term care facilities. There's also some very unique exposures that not necessarily related to patient handling, but I really like to point these out, is that they do have to deal with secondhand smoke. Oftentimes more exposure than when the nurses or nursing aides are primary smokers. We found that had more exposure to secondhand smoke than primary smoke. There's no laws to restrict the smoking in homes, so patients and relatives are free to smoke at any time. So you have to deal with that type of things. And then you have issues with pests, where dogs and cats are underfoot oftentimes, can be antagonistic, especially if a patient is responding adversely to a caregiver. And then the other ones are bed bugs and cockroaches, which you have to worry about with equipment. And so oftentimes this where it does impact the repositioning and handling of patients is if you can't put your medical recording device down or other devices down because you worry about it coming in contact with cockroaches or bed bugs, you tend to hold things and become a one-armed worker. And so one of the things that you see there is that you have these pests that you worry because you can't take them outside the house to the next house because you're going to multiple houses. So there's always a debugging that has to also occur, but you really are changing the way you interact with the patients due to the exposures to these insects. A couple other things you have to worry about is the egress and ingress of, and so not just patient handling, but also handling of supplies and equipment that typically are in the vehicles that has to run in. You have more violence issues with high crime rates and patients in more altered mental states. But the biggest one, patient handling, is there's no one to help, and most of the time there's not a lift. It's very unusual to see a lifting hoist or lifting devices that can help handle reposition and patient handling in the homes. So this is a really alarming issue for the home health care workers. So one of the things that you see is there is a lot of handling of moving of patients in home health nurses, particularly nurses' aides. And as you see over the year, they're thousands of times moving a patient on and off a chair. We didn't necessarily capture on this graph the actual repositioning, but we certainly caught a lot of other handling activities, which is of concern for particularly health aides and stuff. So my last part of my talk is coming from, is going to branch out away from my home health or my patient handling one, and this is just more about challenging people. This comes from my plenary talk as president of Human Factors Economics at the annual meeting. But I take my opportunity to really quick to touch base on this concept of zombieism and trying not to become a zombie. And certainly I'd refer you to my plenary coming up, and you'll be able to see the full one. But this is just a quick overview of that. If you look at everyone knows about the zombie apocalypse that you see out on TV. It's the one that you see, The Walking Dead and all these zombie ones. But that's not the zombie apocalypse that I'm talking about. I'm talking about the one that where professionals in ergonomics will go to the lab, go to class, go to work, go to industry, to everything, and just become routine and just show up, do their job, and then go back home. And that is the real one I think our profession needs to protect about those type of zombies. And so one of the things you need to know is, how do you know if you're a zombie? Well, complacency is the key number one. Do you come into your job, to your classroom? Do you, as a student, come in and just sit there and take things in, or do you challenge your professors? Are you into risk-taking in some of your at your job? And risk-taking isn't trying to lean over the side of the machine and putting your finger real close to the saw and seeing if you're going to get your finger cut off. That's not the risk-taking I'm talking about. I'm talking about risk-taking in your profession to really challenge the field, to get better, to become better ergonomists, colleagues to become better ergonomists, and be able to really challenge the field to do this. So it's not about just doing my job and going home. That is a sure sign of a zombie. But if you don't have a passion for your job, everybody started in our field, I believe, because you had a passion for workers and understanding and protecting workers. And if you're not continue to be passionate throughout your working career, then you become a zombie. And this is one of the big issues you have to worry about. So I'm here to challenge you not to be a zombie and take chances in the field, whether that is in the industry, getting out and going beyond your workplace, but really be, identify your passions and really understand how you push those passions. And hopefully ergonomics and human factors is a big passion of yours, and you want to push that out to everyday people all the time. But you also want to be able to network and mentor. And I really want to stress on mentoring. Everybody needs mentoring in the field. And that can be either getting somebody to mentor you or be able to mentor somebody else and really help people that are in the field of ergonomics to push our field beyond it. And really be aware of when you become a zombie, because it's easy to slip into the mode of being a zombie and coming in and just doing an easy thing and leaving and go back to home. But push the field farther. That was my service announcement, but I would like to thank special thanks to my funding agencies that put in for the research that was involved in this, as well as key personnel that worked on all the different studies, particularly Susan Katowski and Bill Maris for the spinal loading model that we used in the actual investigation of the tools. And then at this point, any questions?
Wonderful. Thank you so much for sharing with us. I do have a few questions that are coming in, and at this time, if you have a question, please feel free to enter it into the webinar chat or Q&A function. Our first question, someone was wondering if your data was collected from California labor statistics.
The first data that I showed that were the summaries, those were all, it was a review article we did of studies in the literature published, and that was worldwide, not just in the United States. The figures later on that were injuries were from the Bureau of Workers' Comp in Ohio Bureau of Workers' Comp. No, so it was not in the state of Washington. I did not have access and do not have access to that data at this point in time. Although 2 days ago I started talking to a researcher out there about looking at some trends between the two.
Thank you. We also had a compliment. They loved the zombie analogy. It made their day, so thank you.
Well, like I said, my full presentation that I did for the opening plenary at HFS will be up online soon. I would really suggest there's a much more detailed presentation. I even have a checklist of how do you know if you're a zombie or not, and it goes through a much more push to not to be a zombie, and this is one of my big sort of initiatives that I've been trying to push on getting people to be more active in a profession.
Thank you. We do have another question. When you mentioned repositioning devices and their effect on compression and friction forces, were you able to relate also to placing and removing of the devices?
We did not look at that particular one. That is certainly a concern. With all the ones that we looked at, you had to, you would have had to put them underneath the patient, whether that is, the draw sheets or the air-assisted devices, the sliding board, all of them would have, but we had positioned, in the study we did, we just looked at the actual repositioning. We also, part of the study was looking at lateral transfers also. So we were looking at the transferring part of it. In the paper, we listed that as a limitation of the study, that we would need to really look at how much easier or more difficult each of the devices getting them under. There certainly was a discussion of having what would it take to have the devices underneath the patient as they came into the hospital and stuff, so you don't have to keep lifting them up and down and stuff.
Thank you. We also have another question regarding if you're able to speak to the frequency of use for some of these assist devices. You mentioned that they were common in hospitals, but are they almost always used in these settings? What about in home health care?
Well, I can talk in the home healthcare. I mean, we're just now going out and evaluating actually in-house, following the caregivers. But what I've seen in observations and what we've seen in our surveys that we did, there was very little of, if any, type of safe patient handling devices at all in home healthcare. In the hospitals, I think it's a real hit or miss. The study I did with Kent Wilson using some hover tech international data, we actually saw that there was some usage of devices, but mostly, again, that it didn't differentiate between the devices. And our hypothesis was that was mostly the two-person draw sheet type of ones. So in the observations studies that I've done, that is not published, but we've gone and did investigate in a hospital, we found very little use of any of the devices, actually. And even in a a no lift hospital. But I do think there are some studies out there are showing better results. Some VA work is showing some pretty decent results in some of the studies. But the biggest thing is making sure you have the devices readily available. The other thing is it also seems to be relative to the size of the patient. For a really heavy patient of 300 plus pounds type of thing, they were much more readily use these type of devices. So I don't have necessarily specific numbers or of how much each of the devices were. I think it's in a little too much marketing for me.
Sure, thank you. We have another question related to solutions. We've talked a lot about defining the problem and looking at some of the injuries and illnesses as a result. But from your research, were you able to draw any ideas about the best path forward?
Well, certainly for repositioning, I'll be honest with you, I've seen another product that's been on, and actually at Cincinnati Medical Center, University of Cincinnati Medical Center, I know they're doing a small study there. I'm not involved in it, but it's I think it's called Hercules. Like I said, I'm not trying to state any type of marketing on this, but the context or the premise of it is a large sheet that gets sort of moved up in bed, the patient, so that it's a long, but the sheet is coiled up as the patient gets moved down. The sheet is coiled up at the head of the bed, and they move the patient back up in bed without any need of anybody lifting it. So, like I said, I haven't seen any evaluations of it, but the concept certainly is there. I imagine in the near future, we're going to start seeing exoskeletons come out there, and helping nurses reposition and transferring patients. I think the book is out, still out on that, on how effective that will be in the long term. I do know ceiling lifts are certainly more more effective and more widely used than other devices like the ones I showed you. So those type of things I think are out there, and I think would be down in the horizon moving forward. I think one of the big things is, especially in the home health, is right now there's really not much going on in that field or that area sector of the healthcare on any type of devices or assists in that realm of things. So I think that's where the areas that I see in the future would be of need.
Great, thank you. And you actually touched on two other questions that we got. One related to if you have done any research into utilizing ceiling lifts with repositioning sheets.
I have not done that. I know others have done it in the field, so I can't. I know they've been shown to be highly effective, more effective than the floor units. Obviously, there's a much more greater expense for ceiling lifts, but I know there are more widely used. The usage utilization rates are much higher with ceiling lifts because it's right there. They don't have to go find it and those type of things. So I think that, what I've seen in the literature is certainly that, but I've not done anything specifically.
Great, thank you. And also we had a question about exoskeletons. Someone was wondering if there were any studies that on systematic study design that you're aware of as it relates to exoskeletons.
In healthcare or in general?
I think specifically with the issue of trialing exoskeletons and similar devices for healthcare workers.
I have not seen anything yet in the healthcare arena of it to say that. That doesn't mean they're not coming. It's that area is exploding very rapidly, and I think that there's a lot of money going into those type of devices. But I think the research is certainly lagging behind. We've had a lot of, I would say, more simple evaluations than the prospective longitudinal type studies that that you're going to need to know and understand when you have a device like that on your body that is changing the mechanics internally, and then what happens when you don't have it. So,
thank you. We also have a question related to working with patients who need to be transferred from the home to the hospital, as an example. Are you aware of any solutions for those types of transfers? Or do you have any recommendations?
I think this is probably less. I mean, I know a group up at Ohio State has been doing some stuff with different types of stretchers that go into in and out of ambulances. But I don't know of any research to date to really start addressing those issues out there. I think that's a great observation and studies that probably will need to be done in the near future.
Great, thank you. Also on the train of studies that could potentially be done, someone was inquiring about the role of assaults by patients and if that's something that's taken into consideration, especially in the psychiatric nursing setting.
Yeah, in a home health care or let's say, in hospitals, I've done a couple of studies. One is we were doing a study at Children's looking at near misses, and particularly, one of the big areas is the psych ward in that hospital that has a lot of issues potentially to that. But there are a lot of individuals out there. I do have one PhD student that is looking at the not necessarily assaults, but the violence in home health care. So we are looking at that because there were quite a bit of assaults, not necessarily to the assault level, but violence against caregivers that they reported instances in the surveys. And now we're going out and observing the caregivers and seeing if there actually is assaults. And a lot of times those violence is either due to dementia and Alzheimer's. It's certainly a big issue. But there's also issues with violence with the neighborhoods oftentimes, because with home health care, you go where the patients are. And one anecdotal type of story we got in our surveys or interviews when we did them was about one that went to a very bad neighborhood, and they ended up having a police officer come over and say, "You can't go in here. It's you know where you're at." And the nurse said, "Yeah, I know where I'm at." And so the police said, "Well, I have to take you there." And she said, "No, you can't because of HIPAA." So they have to deal with, very different circumstances with these neighborhoods of going in, oftentimes without safety of professionals and stuff that could protect them. And then with the opioid issues, you have the people coming up thinking, oh, you're a nurse, you might have drugs type of thing is another violence that's out there. So there are many unique aspects of the violence. And I think that's one of the things out there looking at the violence with, especially in interaction with patient handling, because, if you have, my hypothesis, we were trying to do a study a while back with one of the researchers here. We were looking at, how does, if a person's, violent, how would a caregiver react with a patient that's been violent before? Do they actually go in and hold them differently than they would if they don't have to worry about somebody hitting him or something? So violence is a big area that interaction with the patient handling it does need to be investigated.
Great. Well, thank you so much again for joining us today and for answering all of these questions. I do have a couple other comments from some of the learners. Someone who works in the VA wanted to let everyone know that they've implemented a safe patient handling and mobility program in acute and long-term care in the home and in communities. And that includes ceiling lifts and powered floor-based devices. And they've provided their email address in the chat. So if anyone wants to reach out to that individual, Tony Hilton did provide his email address if you want to know more about the VA's program. And someone also wanted to point to a study conducted at Washington State dealing with assaults in one of their psychiatric hospitals. So thank you all so much for those resources. And we will be resuming the NIOSH ERC webinar series on January 15th, 2020, with a presentation by Dr. Carissa Harris on the impact of a scope stand on biomechanical exposures during simulated colonoscopies. Also, our final webinar of 2019 will be on Wednesday, December 11th on severe silicosis in engineered stone fabrication workers, U.S. and global perspectives. And this webinar will be presented by Dr. Robert Harrison, Clinical Professor of Medicine at UCSF and Public Health Medical Officer with the California Department of Public Health. You can learn more and register for these upcoming events at coeh.berkeley.edu. And you can also subscribe to our YouTube channel where you can find recordings of these webinars and more. Thank you again so much for joining us, Dr. Davis. We really appreciate it.
Well, thank you for letting me talk.
Have a wonderful day, everyone.